Hello, my name is Dr. Jabir. I'm a vascular surgeon in Southern California. I will be presenting the benefit of staged versus non-staged treatment of endovascular thoracoabdominal pathology. The predictors of spinal cord ischemia are aortic coverage, prior infrarenal aortic surgery, shaggy aorta, unilateral iliac artery occlusion, bilateral iliac artery stenosis, and left subclavian artery occlusion. The extent of aortic coverage is an independent risk factors for spinal cord injury or ischemia. The extent of coverage more than 20 cm is an independent factor, basically. And the more you cover, the more likelihood that you can have a problem with ischemia, with spinal cord ischemia, especially in the lower in the lower T10, T11, T8 to T11, T12. This area where the artery of Adamquist basically the coverage of this area also increase. 1 in 8 patients have spinal cord ischemia. The most important risk factors for spinal cord ischemia are basically have been multiple studies out there discussing this. The most important is really the extent of coverage or the type of aneurysms. Type type 2 aneurysm has been associated with more ischemia if you do that once. There are multiple studies that showed this effect. Age, aortic coverage, basically depends how much you cover, and basically the duration of the procedure, so more than 300 minutes, radiation, contrast use. So all these things been shown in studies that increase. So the most important risk factors are, like we said before, it's really the extent of coverage and the type 2 thoracoabdominal aneurysms or pathology, because you have to cover so much at once. Duration of the procedure is also associated with very high risk of spinal cord ischemia, and it's been shown in multiple studies, and the cutoff number was at least in one study is about 300 minutes, which is not uncommon in these complex procedures that you would spend that much time. Hopefully most of the time we spend less time than doing these procedures, but that's an independent risk factor. And then fluoroscopy time. So if you use fluoroscopy times about 190 minutes, that's also a risk factor of developing spinal cord ischemia. So in the state of California, it's if you use fluoroscopy more than 60 minutes, essentially you have to answer at the hospital and it gets reported to the board. So we try to not use more than that. And with the newer technology and fiber optic technology, etc., fusion technology, we are using less and less fluoroscopy time. So the extended coverage is the most important risk factors: fluoroscopy time, higher contrast volume, duration of the procedure, single stage of endovascular repair of the thoracoabdominal procedure, just because you have to cover so much at once and it takes more time to do that. In this study, they looked into basically 1,681 patients. These are very high volume operators throughout many institutions who do these a lot. And they looked into basically 1,681 patients who underwent FEVAR or complex BVAR. The rate of spinal cord ischemia was 7.1%. 3% of that was a transient deficit, meaning you have ischemia but you treat it, you put a lumbar drain, or you increase their hemoglobin, or you do or increased blood pressure, but it was a transient deficit, and they came back, and 4.1% was permanent neurological deficit. This increased, basically the risk of ischemia is increased in Crawford 1 to 3, and again that depends on because you cover more in these cases. And what they found is median survival if you have no deficit in 60 months, basically 60.6 months. If you have transient deficit, 62.4, which is obviously is not significant. But if you have a permanent deficit, it's 24.1 month. So this almost you survive half the time, which is understandable because there are so much comorbidity with ischemia. So again, Crawford 1 to 2, 3. If you do that once, these aneurysms are at higher risk of ischemia because just you cover so much. In this study, in terms of spinal cord protection practices used during the vascular repair, basically in the Aortic Research Consortium, what they found, basically survival rate is less when you have permanent paralysis, as you see here. And again, these are number of patients you see in the red plot, and the survival, worse survival was in those patients who had permanent paralysis than those without spinal cord ischemia. And there's a little bit of a better outcome in those patients who had transient event and recovered. This actually, so you see the spinal cord ischemia impacts the mortality rates in these patients, and that's very important. The incidences of predictors and outcomes of spinal cord ischemia in elective complex endovascular repair. Again, this is a study by high volume centers. What they found is also again, the red line here, it's the survival probability. So if you have a spinal cord ischemia, you're more likely to die sooner than those who didn't have spinal cord ischemia. And again, in this study, and the impact basically, and then that impacts on the payments and the insurance claims and the cost of treatment. So the spinal cord ischemia is a major disability that increases the cost of treatment, and also is associated with multiple other diseases such as decubitus ulcers, respiratory problems, DVT, etc. So what they found in this study, females with female AAA patients and thoracoabdominal patients with cardiac arrhythmia at higher risk of developing spinal cord ischemia during these complex procedures. The occurrence of this event was strongly associated with higher complication and worse short-term and long-term survival. And again, because when you have spinal cord disease, you have significant comorbidities that cost more to treat. And this study, again, it's a study of 351 patients who had EVAR, BVARs, and thoracoabdominal repair. Basically, there was about 13% developed some neurological symptoms. Among them, there was 4.8%, which consistent with the literature, had permanent disability. Spinal cord ischemia was associated with, again, Crawford 1 to 3. And again, this basically it's directly proportional with the extent of coverage of these patients. Now, if you compare staged endovascular repair of thoracoabdominal aneurysms versus not, it limits the incidences and severity of spinal cord ischemia. So in this study, there are 59 patients. Non-stage spinal cord ischemia rates were about 37.5%, and that's transient and as well as permanent. When you have staged rate is about 11%. So clearly there's difference in the two, because again this will probably related to not only the extent of coverage, but also if you do a full thoracoabdominal aneurysm endovascularly, that would be a longer time, longer contrast, higher fluoral fluoroscopy time. So you combine all the risk factors and you put them in that one stage procedure. What you find here basically trends toward improved 30-day survival when you do these procedures in 2 stages as opposed to 1 stage, and that's understandable. Again, the longer you do the procedure, the longer you cover, the more likelihood that you'll have spinal cord ischemia, not only because the extent of the coverage, which is the most important, but also more contrast, more fluoroscopy time, more bleeding, anemia. You bleed more than what you think in these cases. Actually, you bleed quite a bit, not realizing that during these procedures, just because of the flushing and sheaths and things like that. You bleed more than what you think you bleed. This study looked into, again, it's a very large study from multiple operators who are very high volume and very high volume institutions. They looked into multi-stage and single stage, and they looked into about 1,947 patients. Again, stage 1 to 3. Thoracoabdominal 1 to Crawford 1 to 3. They looked about 939 patients had single stage. Multi-stage was done about 1,008 patients, and what they found is staging elective fever or BVARs 1 to 3 was associated with decreased risk of mortality and or permanent paraplegia at 30 days within the hospital stayed, and also had higher survival rates in 1 to 3 years. So you see study after study and consistently with the large volume patients shows the same value, that multiple stage procedures actually has better survival and less spinal cord ischemia. Again, I apologize, there's a typo here with the EVAR up in the section here. I apologize for that. This study is a systematic review of multiple studies, about 27 studies. One of the studies was including both arms, staged and non-staged, treatment for essentially 1 to 3 thoracoabdominals, and they also looked into type 4. They looked into the incidences of outcome in terms of staged and non-staged procedures. So the total patients were about 2,300 patients. What they found that staged approach reduces the spinal cord ischemia rate independently of timing and methodology adopted in terms of these multiple studies. And there are about 20 studies of those that they looked into a staged approach. And what they looked into, there's increase in survival, however, there was about 1.6 of mortality has happened in these patients during the stage. So when you do stage procedure, you just go on and do it before too much time goes on. But this is another clear evidence that when you do endovascular staged procedures, is associated with better survival, better outcome. This is basically when you compare the clinical outcome with 1 versus 2 staged hybrid approaches in thoracoabdominal aortic aneurysms. The open approach is different. I think it's hard to do staged versus non-staged when you replace the whole aorta, but the endovascular approach is clearly there is benefit from that, just because probably more involved in manipulation and time. But here what they looked into clearly, even in hybrid approaches, when you do open hybrid approaches, the staged procedures has less spinal cord ischemia again. And this spinal cord ischemia again means is less mortality, less comorbidities, and so forth. So in this study, it's somewhat controversial whether you drain or you don't drain routinely. It depends on the institutions, it depends on the operator. Most high volume operators do not drain routinely if they have the ability to place emergency drain. In other words, if you perform a TVAR and then the patient has some neurological event, you gotta have a team that can place a lumbar drain right away. If you do not have that, then the recommendation would be is to essentially place a drain. And there are other group of operators who just placed a drain routinely. My point is, placing a drain is not just walk in the park. Also, it has complications. So you almost like if you do these procedures in one stage, you almost have to place a drain in these patients. But if you stage it, you don't have to place a drain. So drain-related complications was about 10%. Severe complications, 5%. Spinal cord injury was almost 31% in this study. So drain is not just a benign thing to do. And that's why it's very controversial. And, whether you drain or you don't, routinely, that's a different issue. But there's no question that drain decreases the risks of a spinal cord ischemia. The question is, if you have ability to do it right away or not, and that's becomes key issue. If you don't, obviously you need to drain these patients. So other thing that helps to prevent spinal cord ischemia is mean arterial blood pressure is above 90, hemoglobin above 10. There are other things that can be done and can be watched. A lot of times intraoperatively we monitor these patients. If they have any problem, we can address that with blood pressure or address that if they're anemic with blood and so forth. In summary, we went through a clear evidence that extensive aortic coverage is a major risk factor for spinal cord ischemia. Spinal cord ischemia is associated with higher mortality, associated with other comorbidities that leads to death as well, pneumonia, DVT, decubitus ulcer, and so forth, psychological problems. There are substantial evidence that we went through that shows that staging these procedures is a safer approach, and that was clearly seen in the multiple large studies with multiple institutions, as well as large meta-analysis with the 27 studies. Again, as we said in the last slide, you're more likely to place a lumbar drain if you're going to do this procedure at once than just staging it. And lumbar drain has also its own risks of complications and so forth. Although this topic is a very controversial and the jury is not out yet, but I personally favor a selective drainage than not in these patients, if you're doing, especially if you're staging these patients. But again, you need to have available team 24/7 that can come and place a lumbar drain immediately so the issue arises. Otherwise, it's safer to drain these patients ahead of the time. Two-stage procedure clearly decreases mortality, decreases risk of spinal cord ischemia, and improve survival. This is the end of this presentation. Thank you very much.